Welcome to Pushing the Limits with your host, Lisa Tamati, where it's all about health optimization, anti-aging, longevity, and being the very best you can be. Brought to you by lisatamati.com.
Hi everyone, Lisa Tamati here, and welcome back into Pushing the Limits. Today I have an interview with Dr. Samantha Newman, who is a specialist in women's health and is a female GP. Is her website, femalegp.co.nz, which you might want to go and visit after this episode. She is someone with a gynecological background in surgery and so on, but has now stepped into the GP space and specialising in women's health and hormones. So a real expert in this space particularly. So I hope you enjoy this. I think women's health is always sort of underrepresented in general, and it's always good for us to be talking about women's health. So I hope you enjoy this episode. Before we head over to the show, please go and check out my new company, Avum Labs, avumlabs.co.nz, the AEVUM, and our new product, Rejuvenate, which we've spent 2 years developing a formulation that's going to really, really help with your immune system, your cellular health, your gut health. It really is a breakthrough formulation with over 15 years worth of clinical research in behind it and a really world-class scientific advisory team, not just me on my own. So it really is worth checking out, and we're having some incredible results with it, with people's immune system, with autoimmune, with gut health, with leaky gut, all of the sort of age-related immune diseases that happen. It can help with natural killer cell activation. It can help with the barriers in your body. It can help support your healthy microbiome. It can help with antioxidant, anti-inflammatory, and really, really powerful formulation. It should be one of your foundational supplements. So I'd really love you to go and check that out. Go to avumlabs.co.nz, and otherwise you can find it also on my shop at lisatamati.com. Hit the shop button, and in the top navigation you will see Rejuvenate Pro is the name of the formulation, so go and check that out. Also just wanted to mention Health Span Hacks, which is a course that I've done with my favourite teacher and mentor and scientific advisor for Avum Labs, also Dr. Elizabeth Yurth, and we've done a course called Health Span Hacks, How Not to Die, and this is really a great short course that you can do to help empower yourself to take control of your own health, learn how to do research, learn how to understand your own blood work, learn mindset and other techniques to really help you take control of your future health. So I hope you do check out Health Span Hacks. Now over to the show with Dr. Samantha Newman. Well, hey everyone, and welcome into Pushing the Limits once again. Fantastic to have you all with me. Today I have Dr. Samantha Newman with me, who is going to be talking everything about women's health and not thyroid, hormones. We're going to be talking hormones today. I've just been studying thyroid overnight, so I'm mixing my P's and my Q's. But welcome to the show, Dr. Samantha. Wonderful to have you. Really excited to learn from you today. Before we get into the meat and potatoes of what we're going to be talking about, can you just give us a little bit of a background on yourself and how you got into this space particularly?
Yeah, kia ora. Thanks so much for having me today. So I'm a GP. And I'm currently working in Napier, which is on the east coast of New Zealand. I'm originally from London, and that's where my family all still are. And I started medical school in Bristol in southwest England, then went to London because I needed to go back home and near my family. And then a couple of years later, after starting obstetrics and gynecology training and being on an incredible dream job, my husband and I decided there was more to life and more to spending time with each other and medicine. And so we moved to New Zealand. And the lady who's now one of my very good friends misread my CV at the time. And so I rocked up in New Zealand to be on call for the whole of Christmas as a semi-junior doctor in rural New Zealand. So, baptism of fire, and all the consultants suddenly didn't get their Christmas off. But it meant that I got really good exposure, learning, and, being a typical female, not particularly confident, but actually competent. And, but then I realized, we have our patient zeros, And one of my patients, I had the opportunity to support her through a stillbirth, which was one of my first patients in New Zealand. And then she had an ectopic pregnancy, which required for her to go to theatre. So that's where the pregnancy starts developing outside of the womb, which can be really quite dangerous, particularly if not identified. And unfortunately, she had a miscarriage, and I was on call then as well. And we had to take her to theatre. And by coincidence, the week after that, my grandma got sick, or it was identified she was sick. I knew she was sick prior in England. And one of my friends was like, go home, just go home. And I realized in New Zealand, there's a real importance of family, of whānau. And I said, I want to go back and spend the time with my grandma. And everyone was like, yeah, cool, go. So 2 weeks later, I hopped on a plane to England and spent a week with my grandma, staying at her house. And on my journey back, I was reflecting on work and life. And I was like, why am I doing obs and gynae when I'm still terrified that I'm going to get this baby out alive and I'm good enough surgically? But this patient told me what I love is journeying with her and her family through the challenges. And so then it was a bit of a light bulb moment. From that moment on that plane, I decided I'm going to work out how I can be the best doctor in the community and learn about women's health and what I can do. Wow. So that kind of set me up, and I focused on, it was great. The trainees loved it because I was like, you can go to theatre and do all the complex cases. I'll just chat to the patients. And all the conversations that I hated as an obs and gynae doctor, like, should I take this medication? Should I have this folic acid or this one? Or should I take antidepressants or not? Or I've got recurrent thrush again, which I hated as an obs and gynae doctor on the ward in 5 minutes.
Yeah.
Then I realized that when I could explain and develop a relationship and actually go back to my computer in the evenings and read about it, I was like, this is what I want to do. So I spent a year or two more in the hospital and a bit of locuming in obs and gynae, and got comfortable with the procedural skills that I would be doing in the community. So Mirenas, IUDs, contraceptives, pessaries as well, and genital pessaries, which would be quite a good opportunity to talk about because nobody ever does.
No. Yeah.
And then I didn't tick all the boxes for GP training in New Zealand because I'd trained in England. And this incredible doctor in rural Hawke's Bay said, Sam, I'll supervise you. Come under my wing. Lovely. So I spent 2 years with him in central Hawke's Bay and just learned how to be a GP. And so then the reason I've kind of gone about it for explaining that way is because there was no other female doctors. So suddenly it was, I need to see the female GP. I need a female GP. And there was nowhere that anyone could see someone or do these procedures. And then over the next few years, as we move around practices, I still got that. And then I got a reputation for, you need to go and see Dr. Sam. And the practice I was in said, you can't see anyone else. And I was like, this is my dream. I have realized forever that I want to do women's health. And on retrospect, my undergrad was in neuroscience, and I've done bits of psychology. I loved psychiatry. I did some research projects at Great Ormond Street in pediatric neurology. I got a grant to go to New York to do pediatric neurology, did projects on heavy menstrual bleeding out of the Centre of Haematology in London. So, all of these things suddenly, like, I've spent years wanting this, and they said, you can't do it. And I was like,
yeah, brilliant.
Are you crazy? Like, what? You just need to work like all the other doctors. And I was like, I don't do that. Like, that's not going to happen. So in Hawke's Bay, it's quite small. And one of the nursing managers said to me, I worked with your husband. I'm from England as well. My daughter knows who you are. Come and have a room here. We'll support you if you need any nurses in the room next door. And that was it. So 6 years later, I'm running my clinic and living the dream in that sense.
Oh, that's what a background story. Like, what an incredible journey you've been on, and how important. And actually, I got to know you through one of our mutual clients who's connected us and said, you two ladies need to talk. You're both working on my case, but you need to talk, because this is really, it's really hard for me to find people like you in New Zealand to send people to, because there's certain things I can't do, and I can't prescribe, and I can't do certain things. And when I send a lot of my clients who are having hormonal difficulties, whether it's from menopause or whether they've got endometriosis or PCOS or whatever the case may be, I'm finding when they go to their normal doctor, they're just not getting the care that I would like for them often, and there's certain limitations within the system that I'm finding. So I'm really stoked to meet you, and you'll probably be getting a few people sent your way from me. But so let's, there's so many directions that we could take this, because like women, our bodies are pretty amazing. Like, we are Ferraris, we are highly tuned and complex beings that really need someone who's got a lot of knowledge like you to be dealing with all of these sorts of aspects. What is the number one thing that you would like to talk about on this show? What are you passionate about in regards to women's health that you want women to know about? Let's start there.
Oh, really good question. It's not going to be a succinct answer, but I think it's about understanding you. So as a whole. So what I have realized over the years, and probably I've tried to develop strengths in communication and figuring things out in a partnership. Mm-hmm. And, a few years ago, when I would say to someone, I don't know, they would get a bit frustrated with me. I'm like, when I'm like, I don't know how your body's going to react. But I think we need to look at that as being a positive rather than a negative.
Absolutely.
I always go back to, what is your hormone journey? So I've actually trademarked, which kind of I got accepted, which was a bit crazy, the hormonal hikoi. Mm-hmm. So for those listeners outside of New Zealand, hikoi is journey in Te Reo Māori. And so what I learned from my wahine Māori, my Māori patients, female patients, is that you've got to look back to understand where you are now and actually how to support you most moving forward. Mm-hmm. So even just kind of, for example, if I've got a 45-year-old new client who's come and she's saying her mood's down a bit and she's quite tired. And, years ago, and for most people, that's a heart sink patient. But that's my reflection of it. And why do we as doctors have, and the same as I imagine other professionals have, those like heart sinks? It's because we don't feel we can help you, and that's our reflection. That's our responsibility. But actually what I've realized, so if we go back to our 45-year-old woman and she's tired, I'd be wanting to know, well, what does tiredness mean to you? Or how long have you been tired for? What's the difference? And then I often go back to just getting a foundation with hormones. So going back to what was puberty like? Quite often somebody would say, oh, well, I may have developed some migraines then, or I had to have some counselling at school, or they remember nothing. And, that
another sign.
Once again, that kind of remembering nothing is also really significant. Mm. And it's just, you don't know how to interpret it. Or like, is it that it was totally fine? Or have you just blacked it out and we just don't have that information? Mm-hmm. And then, for example, in this case, periods started, they were fine for maybe 6 months, and then they became bad. So life was harder for her and she started the pill. And she then stayed on the pill until 32. Mm. So for me, someone staying on the pill, and I was like, did you have any mood challenges? Were you happy? And people know, right? They're often like, yeah, no, I was happy. Then I got pregnant really quickly. So that's telling me you didn't know your menstrual cycle in that duration because you didn't need to. You fell pregnant quickly. You got what you needed. Quick children, boshed out together. And then good job, balanced everything. And then 42, life became hard. And often women say, oh, well, my mother got sick, I had all of this, and we just attribute it to the life kind of things. And I'm not dismissing the life situation, but I'm also being a little bit devil's advocate. I'm like, what else could have been going on in your hormones at that point? And then we come to like, where we are now. And I've got someone who had challenges a bit at puberty, started the pill, was good on the pill with hormone stability. Oh, and she had postnatal depression too. And we know postnatally hormones drop. And that's telling me that someone's sensitive to when their hormones drop. And then I'd always ask about, actually, what's your menstrual cycle like now? And some people aren't aware of ups and downs, and others are. And then so I've got to often find I've got to be a little bit creative of like, what was this week like for you? What was that? Or, oh, that was hard. What was going on at that time? And typically in early perimenopause, often times before our periods, before we start menstruating, get a bit harder. So you can get some more hot flushes, sleep can get a bit worse, fatigue can get a bit worse. And often that's what then women say. And I'm like, oh, well, that's a clue for me that it's hormones. And we know if you have postnatal depression, you're more likely to have a challenging perimenopause. And then, for example, like, we can discuss like, I would go into things a bit more in detail, but, why don't we try hormones? Or she's seen loads of doctors and everyone said, you're fine. And so me, with my experience, what do I have in my kete, in my toolkit to support this client here? And I'm like, well, we could try hormones. And over the years, I've just found it phenomenal, the difference appropriate hormone therapy can make.
And
I'm just blown away by that. And I never thought I would be wanting to challenge guidelines that say you can only use hormones for moderate to severe vasomotor symptoms, hot flushes, because like this lady, it's just incredible the difference it can make. And I feel really strongly that everyone should have that opportunity. And if we can pick up these little clues as well, then I think that will set us up as individuals and as healthcare professionals even more to be able to support our clients as is hormones the right option or not too. So I kind of almost think with perimenopause that there's almost possibly like two types. One is you've got everything hormonal in your background, whether you've put it together or not. So puberty was hard, PMS, eating disorders, migraines, endometriosis, postnatal depression, felt amazing or horrific in pregnancy, and either loved the pill or had to be on one specific pill only because all of the others were a disaster. It's either one way or the other. And so then when you come to midlife, even late 30s and 40s, it's obvious. I'm like, well, we've got all of these things. Clearly it's hormones. Let's give it a go. And we're going to talk about what giving a go means, if that's all right.
Absolutely.
I think that's another one of my
get on a roll.
And then there's the other side where you are totally fine throughout absolutely everything. And then bam, midlife, something hits. And a lot of the time that's dismissed as you've just suddenly gone crazy. And this is why women are known to be hysterical, right? So why can't we try hormones? And for people our age, these are the older women that stopped working, our role models that went off, the women in the, when we have our family gatherings that are at the back of the room rather than at the front. So there's no data on that, is there? Oh, women that fell off the cliff. But there is about rates of suicide, rates of depression, high rates of divorce, alcoholism. So we've got to, I think, look up. We can prevent all that by identifying hormones.
Yep. I'm just saying amen to everything you're saying, because it's it's so crucial that we get this right. And, decades ago, there was the Women's Health Initiative, which put a lot of women off hormones altogether. And I still hear it now today, even though that study has been absolutely torn apart and torn to shreds, right? And you can probably add to the conversation there, but they still have this picture that hormones are dangerous from the get-go, right? Without any sort of framework for that, or why, or what we should be looking for. And it's not that we want to be willy-nilly with taking hormones. We certainly
medications.
don't.
A lot of people don't want medications.
No. And what really gets me is when they, you're told it's all in your head and here's an SSRI, here's a Prozac or something, when we're not getting to the root cause of what may be going on in that person. And, in what I do, I'm always looking at the whole picture. I'm looking at the gut if I can. I'm looking at their nutrient panels and I'm looking at their hormones, and I'm trying to make a whole picture of this person and why they may be now falling off a cliff and not doing so well, and what we can do to back the truck up and then change things, and and then referring out for things like hormones, because I think I've had lots and lots of people that I've interviewed in relation to hormones and different specialties and areas. Like I had Carol Peterson on, who's an expert on progesterone, and that not everybody agrees with each other either, even the experts, right? So we do need to have these robust conversations about, and
healthy, robust conversations.
Absolutely open, robust conversations, so that we can look at it, because each woman is an individual, for starters, and what works for me might not work for you. And so it's really, really key that we take all of the genetics. I do a lot of genetics in my practice, and seeing how that affects your hormones. All of these individual aspects need to be taken into consideration. But at the end of the day, I am a huge fan of people at least looking under the hood, seeing what their hormones are doing and doing something about it, and having the right to get access to hormones at the levels that they need as well.
Yeah, and I think I touched on earlier, I said I want to park, the right hormones. So there's a case that always comes to mind, and she's also consented for me to share her story. And I've kind of adapted it a little bit, but I think that this will help understand. So a 55-year-old lady came to me, had been referred from psychiatry. So a psychiatrist referring a GP, a patient, says a lot, but it's not done, is it? So,
good.
She had moved abroad at 45. She'd had no children by choice, really super career focused, moved abroad, had been on the contraceptive pill forever because it just worked for her. No history of any mental health challenges, nothing. And when she moved abroad, she couldn't get the right pill. So she tried another one and got bleeding. This was in her mid-40s. So she just didn't feel right on it. So she was like, I don't need contraception anymore. I'll stop it. Okay. So she got diagnosed with depression when she was overseas. And then in her late 40s, early 50s, she came back to New Zealand, and her depression didn't get better. In fact, it worsened. And so she got referred to psychiatry. And by now she'd stopped working. And that was a really big thing for her. And this is another one of the things that really upsets me, is where individuals, your career isn't just a career, it's part of who you are. And it fills your cup. And so suddenly we've got a really high achieving female who can't work. And it's like, oh, well, you just need a different career. No, this is who she is and what she's worked for. So we're dismissing her values. So the psychiatrist did a great job of the tools in their toolkit. Like, I'm not criticizing them at all. I think they did a fantastic job. And she went back to her doctor, her GP, who started her on hormone replacement therapy. I think it was a bit hedging the bets when I took a history about that. But anyway, I was like, awesome. That's great. Mood changes, midlife. Why not try hormones? So she came to me, and I'm not expecting everyone to know like the nuances of doses and things, but she was on a 75 microgram patch of transdermal estrogen. And estrogen's, the main hormone that helps most people with well-being and hot flushes and helps the long-term health gains as well. She had a Mirena in situ.
Yeah.
So she didn't need to have progesterone. That was her protecting the lining of her womb from the estrogen. So whenever you have a womb, you have to have estrogen and progesterone. And so she didn't have the medicine called Progesterone, which is our only body identical version of progesterone available. And progesterone in this form can go into the brain and it protects the womb. But in the brain, it can help with calming and sleep and well-being as well, and body pain. And also a little bit of insulin resistance can improve that and lower the blood pressure a tiny bit too. And so she came to me and I was like, great, you're on hormones. What are your clues of your life? Oh, you were on the pill your whole life and you were really well and the wheels fell off when you stopped it in midlife. I increased her estrogen. I gave her some progesterone. I gave her some testosterone.
Excuse me, my mum.
Okay, so what I decided to do with her with discussion, and I sound I'm just going to throw hormones and I'm not, but just for the kind of communication, I increased her estrogen. I gave her testosterone, some progesterone, and something called metformin as well. And I don't know if you've talked about metformin.
I'd love to talk about metformin.
And so if you go to guidelines and evidence for the indications I'm using a lot of this for, it is not appropriate. But then if you extrapolate what other backgrounds going on, and this is where I don't expect doctors to do things that they don't feel comfortable doing, and I'm really comfortable counseling all my patients for these individual risks and benefits. So, she felt better. Wow. She stopped her statin. She stopped her blood pressure medicine. She stopped her quetiapine. She stopped her mirtazapine. She stopped her aripiprazole. And started applying for jobs.
Wow.
And I was like, amazing. Like, yes.
Yes, I was just saying.
And then a few months ago, she came back to me. I got a letter actually 2 months prior from the psychiatrist saying her well-being had decreased. And I was like, oh no, I was wrong. I thought it was right. I thought and then I didn't want to push it. So she knows I have a bit of an open door policy, particularly with these kind of my clients. And so she came back 2 months later, like shadow of her former self after her recovery and things. And I was like, what's going on? And to cut a long story short, 3 months ago, she changed estrogen patch brand. So in New Zealand,
holy crap.
we used to have only one type of estrogen patches available. And then, because it's a public health experiment, you've got everyone on one medication, then they changed it. And
I had the same problem.
With some women, it's not an immediate decrease in well-being. It's a gradual, and it's months later. And so I said to her, how do you feel? Like, what does this remind you of? And she was like, this is how I felt when I came to see you. And I was like, we need to increase your estrogen. She was like, what? I was like, you need to add in 2 pumps of estrogen a day.
So that you eat to the gel. Because
I kept her on the same. So I kept her, which is also, I can do the rationale of science if you wanted to deep dive into any of this. But I was like, okay, well, clearly you're not absorbing it anymore. Like whatever this is, you're not absorbing it. Can you pop on 2 pumps of gel? And I'm going to give you a call in a week because I'm a bit worried about you. And so I called her in a week and I was like, hi, it's Dr. Sam, how are you? And she's like, I'm great.
Amazing. and was that
3 months later, she's still great.
Wow. I mean, I have to share a couple of stories there because I'm finding with myself, with my mother, with some of my clients in conjunction with doctors, where we've been on the patch and then they changed the patch, as you said, and we all, and even the other patch, I'm finding some people weren't absorbing it at all or very little. Older people tend to not absorb through the skin that well because the skin is not so able to uptake. And when I put people on the gel, well, in conjunction with doctors, and for myself, night and day difference. So the gel has been a much more efficient way to get it in than through the patch is what I'm seeing just anecdotally.
Yeah, I think it's that that's a biased audience, as in you're seeing the ones who aren't working and the gel needs to be another option.
Yep.
And I also find that when you've got younger women in perimenopause, they often need higher doses.
Yep.
So, going for 4 pumps of gel just doesn't cut it. And that's a lot of rubbing gel on your body, particularly if it's cold and standing there with your arms and legs wide open kind of thing. So I think I still think for most people, the patch is the better option. And also even changing the location of the body around as well. But I think you're totally right in that if you're not absorbing it or you notice a change in well-being, then we need to have an immediate, you go to another preparation.
Just interrupting the show to let you know about my longevity and anti-aging supplement range. I'd love you to go and check it out. Go to my website, lisatamati.com, and hit the shop button, and you'll see a curated range of supplements, the latest in anti-aging, longevity, health optimization, performance optimization. I've gone out into the world, interviewed the most amazing doctors and scientists, as you'll know if you follow the show, and gone and got some of the best products that are out there. Stuff that I give to my family, that's what's in my range. So go and check it out at lisatamati.com.
And so monitoring is key, right? Like actually monitoring your levels and, getting another test done.
It's because it's all about how you feel. So I think if we took histories, if we actually listened to our patients and they told us, then it's amazing. Like this lady actually, when I did hit estrogen levels, it was really low. So I was like, well, of course you're not absorbing. But there's some evidence that in some individuals, and the British Menopause Society have got this on their guidelines, that for mood improvement, estrogen levels of 400 to 600 can be necessary with specialist guidance. So I think it's really individual. And so that's where I feel really strongly, like if we go back to our 45-year-old, she's got all these clues throughout her life, So if we give her, that sounds really like paternalistic, if we decided for her an opportunity of, body identical hormone replacement therapy would be great, and she didn't get better, one of my biggest things is please don't dismiss her and tell her it's not hormones, because you've only tried one option through one preparation. And with hormones, I say for a lot of people, so for example, if somebody's had premenstrual dysphoric disorder, so PMS, premenstrual syndrome, is really common, like 80% of women have it. And I believe even if your hormones in quote marks in balance, and I know this is in disagreement to a lot of naturopaths, but I believe you can appreciate cyclical change. I think the hormones do so much in our body, it makes sense. It doesn't mean that you're depressed or you can't function, but you can appreciate a change in many symptoms and systems in your body. And however, if those symptoms impact your daily life, prevent you from doing things you need to do, you can be awarded a psychiatric diagnosis of premenstrual dysphoric disorder. I think this is actually underdiagnosed because you don't go to your GP a lot of the time if you have hard periods. You suck it up because you just do. But there's data from 1950s, 1960s, 70s and 80s on managing PMDD differently. And so typically, it's thought that with PMS and PMDD, it's all about the change in hormones that makes you feel blah. But actually, some of this evidence and these incredible pioneering professors have shown that actually high-dose progesterone improves well-being. And then some actually cannot stand progesterone at all. And so I've got some women who I have on a synthetic progestin.
Really?
Because it doesn't cross into their brain and they feel better.
Wow.
Yep.
So I would have thought, synthetic progestin's bad across the board.
No, for some people it's much better.
Wow.
Like the minority, don't get me wrong, but and then there's others that because it's about the change, that we cannot give and take away any progesterone or endogenous or your body's own progesterone, so we have to block it. So then often PMS kind of then can evolve by the increased hormone sensitivity and change into perimenopause. So if we go with those principles that I just cannot believe have not been built on for it's Women's Health Day, but
We
decades.
don't get what we should.
Yeah, what you knew
Yeah.
for decades. Well, it makes sense that 95% of women will feel better with progesterone. And it will improve your sleep. It will improve your body pain. I've got women out of wheelchairs from having appropriate progesterone.
Holy crap, that's amazing.
I took progesterone for a bit to see what would happen after the flood. My PMS got a bit more challenging. And I was like, I noticed this in my patients. Why don't I try what I prescribe? And I maybe became an insomniac for 3 months, and my husband was about to divorce me. So, you know, and this
So
is
we're all different.
We're all so different. And I didn't realize I was that incredibly hormone sensitive until that. And I'm like, I'm a doctor. I like to think I'm good at what I do. And honestly, it was awful.